Today's topic is uterine rupture. Basically, the uterine rupture is a medical emergency and its immediate surgical intervention is required. The treatment typically involves an emergency C-section and repair of the uterine scar. Sometimes it ends up into the hysterectomy also. So it is very crucial and difficult condition. That's a ruptured uterus, and it is a grave obstetric complication. It is associated with a high maternal mortality, perinatal mortality, and the most important thing, it can occur during delivery, during pregnancy, and during labor. And every second of the time is very crucial when we diagnose, when we treat about the uterine rupture. The incidence of the uterine rupture is 0.05% of all pregnancies, 0.8% after previous lower segment cesarean section, and more than 5% after the classical cesarean section, though the incidence of classical cesarean section is very low nowadays, but still it is very important. Then the scar dehiscence has the incidence of 0.6% in pregnancies with previous cesarean section, and has more favorable outcome for both mother and the fetus who does not end up into the uterine rupture. How to define the uterine rupture is a separation of muscular wall of the uterus and occasionally happen during the later weeks of the pregnancy. Now, the uterine dehiscence involves myometrial separation at the site of uterine scar from previous pregnancy and a uterine serosa remain intact. So, most important point, it involves myometrial separation and serosa intact. On other hand, it involves the entire thickness of the uterine wall, resulting into the communication between the uterus and the peritoneal cavity. And the uterus rupture basically is a separation of the old uterine incision and rupture of the fetal membranes so that the uterine cavity and the parietal cavity directly communicate with each other. The dehiscence of the scar does not involve the rupture of the fetus membranes, and the rupture is most acute while dehiscence is gradual. So 3 points are important. One, involvement of the whole layers of myometrium, but the serosa is intact, and it's no communication between the peritoneal cavity and the uterus in a dehiscence. Dehiscence is a gradual, rupture is very acute, and in a rupture, the whole layers goes up and there is a communication between the uterine cavity and the peritoneal cavity. So how we define it? What are the causes of uterine rupture? During pregnancy, number one, if a weak scar of the previous operation of the uterus and the history of the cesarean section or the VBAC being given. Vaginal birth after the myomectomy or the excision of the uterine septum is one of the reasons. Previous perforation of the uterus, probably maybe with a DNC or with a hysteroscopy, or a history of forceps delivery and having a perforation. So basically the two division we can do. If there is a classical cesarean section incision, there are chances of 5% rupture. That's an upper segment. In a lower segment, if the cesarean section is being done, the chances of ruptured uterus is 0.5%, means 5% with the classical and 0.5% with the lower uterine segment. So clinical presentation is also the early presentation, there is a dehiscence, and then a late presentation is completely communication between the peritoneal cavity and the uterine canal is there. During labor, the uterine hypostimulation, oxytocin with or the pitocin induction or the augmentation of the labor is there. If there is an obstructed labors, for example, macrosmia or the feto-pelvic disproportion, then third is intrauterine manipulation that can also lead during labor, the rupture of the uterus, the internal version, manual removal of the adherent placenta. Then the forcible dilatation of the cervical tear can lead to the during labor the rupture of the uterus, or a very previously the weak scar of the cesarean section of the previous scar. Then the severe uterine contractions all over the contractions through all over the sides, and can they lead to the uterus rupture. So the diagnostic criteria for the uterine rupture is number one, painful late trimester bleeding, loss of fetal heart sound, and inability to identify the positions or the malpositions or anything will be there. Then the ruptured uterus, the diagnostic triad, we say number 1 is a painful bleeding, lost fetal heart sound, and loss of a station. Fetal head is a very little head. It's difficult. Now, the types of incomplete rupture, complete rupture, depending on whether the peritoneal cord is torn or not. So the two types, incomplete rupture and the complete rupture. Traditional classification, the complete rupture, the visceral peritoneum overlying the uterus is disrupted, and incomplete rupture is overlying peritoneum is intact and there is not clinically relevant. Then etiological classification, it can be a spontaneous rupture, it can be scar rupture, or third is a traumatic rupture is there. Predisposing factors for the spontaneous rupture, fetopelvic disproportion, congenital uterine anomalies, or soft tissue obstruction. Scar rupture, there is a previous uterine surgery, previous uterine perforation, these are the predisposing factors. Traumatic or iatrogenic rupture and the surgical intervention being done, internal version, forceps delivery, manual removal of the placenta, or the destructive operations can lead to uterus rupture. And medical intervention also, for example, the uterine stimulation. Now, these are the signs and symptoms of uterus rupture. Number 1 is abdominal pain, tenderness, shock, vaginal bleeding, undetectable fetal heartbeats, palpable fetal parts, cessation of the contractions, sign of intraperitoneal bleeding, and the most common sign is the sudden appearance of fetal distress during labor. So these are basically 3 points. Character of bleeding is painful, placenta location normal, and third is there is a ruptured uterus, complete laceration of the pathophysiology of the uterus is laceration of the uterine wall. And again, the risk factors in the classical cesarean section, previous myomectomy, management, uterus repair, hysterectomy, and complication, maternal and fetal death. Diagnosis is probably the safest and most useful imaging technique during pregnancy is ultrasonography, and sonography findings suggest include extraperitoneal hematoma, intrauterine blood, free peritoneal blood, empty uterus, and gestational sac above the uterus, large uterus mass with a gas bubbles. So the treatment, what are the principles for the treatment of the uterine rupture includes number 1, intensive resuscitation, emergency laparotomy, broad spectrum antibiotics, and adequate postoperative care. Intensive resuscitation is correction of the hypovolemia from hemorrhage, sepsis, and dehydration. Intravenous broad spectrum antibiotics, cephalosporin, metronidazole combination, monitor to ensure the fluid and the blood replacement. Blood volume expansion may worsen bleeding and damage vessels, so the laparotomy should not be delayed. Once the condition has been improved, it's our responsibility to get the laparotomy done and deliver the baby out and suture the uterus if possible. Now, the surgical options, first and foremost, emergency C-section, delivering the baby and repairing the scar if possible. But sometimes we have to go for the hysterectomy, the treatment of choice, except any other compelling reasons to preserve the uterus. Total or subtotal hysterectomy can be done. Rupture repair occasionally may be forced to repair, and sometimes the repair with a sterilization, treatment of choice, except any other compelling reasons to preserve the uterus. Not an attractive option, may be useful, especially those who are not able to remove the uterus and unskilled hands. Sterilization is one of the things, but it's a really serious issue. If we are not able to repair properly, then it's also the problem. A death from the uterine rupture is not uncommon. Mortality appears to be higher in the women who have unscarred uterus when the rupture occurs outside the hospital. Overall mortality 15.9%. Perinatal morbidity rate associated with the uterine rupture ranges from 8 to 56%. Now, these are the preventive measures for the uterus rupture, a good, very good, respectful antenatal care. High risk cases should be able to diagnose right time referral, right time diagnosis of the use of oxytocin very seriously and probably done to be in a very proper manner. History of previous cesarean section and augmentation of the labor is very, very important. Now, to note, during the trial, the scar, watch out for the fetal heart abnormalities. any maternal tachycardia, vague abdominal pain between the contractions, and the suprapubic tenderness, vaginal bleeding, and bladder tenesmus. So while with the things which are in our mind that they can be the cause of the uterus rupture, so it's another important point. So thank you for the attention. Thank you so much.